I'm very glad to be here with you today for our regular annual meeting of pediatric oncology here at the Mitera, as always organized wonderfully by Dr. Cosmidis. So today I'm glad to have the opportunity to talk about cancer predisposition syndromes and to address the question, is it time to implement the screening? Well, as pediatric oncologists, we are often faced to the question coming from the parents, why did my child get cancer? The truth is that we don't have the answer for this question. Many years now, we know that adult cancer and pediatric cancers are different from a biological point of view. We have learned recently from large-scale genome analysis on tumor tissues that in adult cancers, the mechanism that is responsible for the tumorigenesis relies on the accumulation of a high number of somatic mutations in a multi-step process, ultimately leading to the malignant transformation of the cancer cells. On the opposite, in pediatric tumors, we have few numbers of mutations, and we know that pediatric embryonal tumors develop under the influence of a genetic dysregulation of a unique driver factor. In some cases, this driver mutation, these genetic abnormalities that we encounter in the tumor tissue can also be present as a germline mutation of a cancer predisposition gene. So historically, the first description, the first report about an hereditary cancer predisposition syndrome goes back to Dr. von Recklinghausen, who in 1882 published his monograph on what we know now, all know as neurofibromatosis type 1, where he documented the hereditary disease characterized by café au lait spot, peripheral nerve tumors, bone abnormalities. We know now that this is also associated to brain tumors and malignant peripheral nerve sheath tumors and other tumors. Later on, in 1971, Dr. Knudson formulated his famous two-hit hypothesis to explain and differentiate two forms of retinoblastoma. And he described the hereditary retinoblastoma as a retinoblastoma with multiple tumors, often bilateral and characterized by an early onset of diagnosis. In 1982, Dr. Lee and Dr. Fraumeni described and published the first report about 4 families in which they observed a clustering of several tumors, mainly breast cancer, sarcomas, and brain tumors. And they, for the first time, speak about a family cancer syndrome. Since then, a long way has been traveled, and if we consider that in the 90s, we consider that the prevalence of cancer predisposition syndrome in children was around 1%, and we think that nowadays we know that this prevalence has reached the 10%, and we still don't know, maybe in the future this prevalence will even increase in parallel with the improvement and the availability of more sophisticated molecular genetic tests. So we just said that up to 10% of cancers in children develop on the basis of a cancer predisposition syndrome. Here in this table, I just wanted to summarize some of the studies that have explored these conditions in children. As you can see, the percentage is slightly different from one study to the other. This depends mainly on which technique has been used and how the population has been selected. In some cases, there are only pediatric population. In some cases, there are pediatric cancer survivors, or like in the INFORM study, there are patients at a high risk, generally in at the relapse. So now, if we look at the landscape of genomic alteration across childhood cancer, we will see that the hereditary predisposition is more common in some specific kind of tumors, such as the adrenocortical carcinomas that are associated to the Li-Fraumeni syndrome in around 50% of the cases. In hypodiploid B allele associated to the Li-Fraumeni in 28% of the cases, but also in high-grade gliomas, especially in the gliomas that are K27 wild type. Also in ATRT, sonic meduloblastoma, and retinoblastomas. And if we look at the genes that are more frequently involved in the cancer predisposition syndrome, we will find that most germline variants are related to double-stranded BRCA repair genes, such as TP53 and BRCA2, and to DNA mismatch repair genes. So now, why it is so important to identify a cancer predisposition syndrome in a child? These diseases are clinically relevant because they are actionable. What do I mean? In some cases, in some cancer predisposition syndrome, we can find out also additional organ anomalies and dysfunction. We can have immunologic function dysregulation. But a point that is very important to me, it is the treatment adjustment, which means that if we know that there is a cancer predisposition syndrome, we will adjust our treatment plan in order to minimize the long-term sequelae, such as, for example, the radio-induced second malignancies or leukemias that can be related to the chemotherapy that we have used in the first line. On the other side, if we know about a germline mutation, in some cases, we can personalize the treatment and adopt some targeted therapy, which is, for example, the cases of the checkpoint inhibitors in children who have a constitutional mismatch repair disease. Another important point is the reproductive counseling. Then also the possibility of offering the genetic testing to the other members of the family. And if we find out the same pathogenic variants in another member of the family, he can benefit of a surveillance protocol. And here we have another very, very important point, which is the surveillance. Because it is clear now that the early tumor detection through surveillance is associated with the improved long-term survival. And as you can see from the survival curves, the study on Li-Fraumeni syndromes shows very clearly that there is a significant difference in overall survival if we compare children, patients and carriers with Li-Fraumeni who underwent a surveillance protocol compared to the patient who did not receive any surveillance exams. The same is evident also in the population of children with patients, with constitutional mismatch repair. Here, the difference is even more dramatic. You see that we have an overall survival of 79% in patients who underwent a full surveillance protocol compared to only 15% of overall survival in patients who did not receive any surveillance exam. So, nevertheless, in the daily practice, sometimes the underlying disease and the family history can be easily missed. This is further complicated by the fact that a mutation in cancer predisposition genes does not necessarily correlate with a recognizable clinical phenotype. On top of this, the situation it could be even more challenging if we consider the de novo mutation in a patient who doesn't have any family history, but still he has a de novo, a new mutation, and he is the first of his family. So, having said this, how should we proceed? To screen or not to screen? Here we have two different and opposite strategies, two philosophies, let's say. We could, for example, decide to test, to perform genetic testing to every single child in the pediatric oncology department. In this case, the advantage will be that theoretically, no cancer predisposition syndrome diagnosis will be missed. We will have the possibility to catch even less usual and less known cancer predisposition syndromes. And there is a potential for new tumor CPS association. The disadvantage is the economic cost of running this testing to every patient in our department, the difficulties of the interpretation of some results, such, for example, the interpretation of the variant of unknown significance. We will have to manage patient and parent anxiety. And also, there are also some unforeseen ethical dilemmas, such as, just to do an example, Dr. Kosmic will talk more extensively about this, the consent of the minors. To participate to these studies is the parent or the legal guardian that gives the consent, but in this way he overrides the autonomy of the child. So we will have to decide from the beginning and in the informed consent if we will disclose the information to whom, to the child, at which age he will find out about the results of these tests, and many other difficult issues that are for the moment even unforeseen. On the other side, we can decide to test only selected cases on the basis of some clinical criteria. The advantage here is, of course, we will reduce patient and parents' anxiety, we will minimize the cost, and we will reduce also the results of unclear interpretation. Here, the disadvantage is that, of course, we will be unable to catch all the CPS patients, and we will miss some diagnosis. So, on which plate of the balance do we put the more weight? Should we sequence all the children? Should we select particular cases? This is a subject of discussion even inside the CEOP host genome working group. I had the chance to participate to the meeting that was held in Paris in last November, and this was one of the subject of the discussion. The conclusion is the same that I report here in this paper. By the way, Dr. Kratz was present at the meeting, we have to choose and stay on one out of these two paths and make a distinction between clinical versus research genetic testing. And here the authors, and this was also the conclusion of the discussion, they recommend that testing outside established criteria be offered only within defined research projects that incorporate careful strategies whereby only carefully selected and clinical meaningful variants that are identified can be validated in a clinical certified laboratory and the results communicated and translated into clinical practice. In practice, this means that we can run large-scale screening studies if we are in the context of a research project and an academic project in order to implement the knowledge of these syndromes. But in our daily practice, common daily practice, it is better to select the cases that will receive this genetic counseling and genetic testing. So at this point, the question is, how do we select this patient, on which basis? The clinical diagnosis of a cancer predisposition syndrome can be facilitated by some existing clinical some tools, such as, for example, some mobile application that everybody can download in his mobile, like the MEPOG application that has been designed by the Canadian group, or using some questionnaires, including the one that are reported in the Jongman's study published in 2016. They are quite similar. These are the most important clinical criteria that can help the clinician to have the suspicion of a cancer predisposition syndrome, going through the list of all these criteria. So even the resident having this application or these tools can proceed one by one to the analysis of the criteria and suggest a genetic counseling. So I think it's worthy to go through the list of these criteria that have to be considered sort of a red flag to let us think, to lead us to the suspicion of the presence of a cancer predisposition syndrome in a child. So first of all, the family history and the clustering of a cancer in a family, especially if it is a similar kind of cancer in several members, or if the diagnosis is formulated at a very young age. And let's always remind to ask about consanguinity. Then there are also specific malignancies that are more often associated to a cancer predisposition syndrome. And we consider that an incidence of cancer predisposition syndrome of 5% or above in specific malignancies is, because of this high probability, is in itself a reason to address the child for the genetic testing. So maybe it's the answer to one of the previous questions that was raised before. And here I provide you, there is a list of some specific malignancies with a relative incidence of CPS. And these are the tumors who automatically should lead us to refer the child to for the genetic counseling or genetic testing. So we see, of course, the adrenocortical carcinomas, choroid plexus carcinomas, desmoid tumor, juvenile myelomonocytic leukemia, but also sonic hedgehog medulloblastoma, hypodiploid leukemia, high-grade gliomas, and a discussion also if we should refer all the cases of osteosarcoma at least for P53. This is an ongoing discussion. Another point is if we are in the presence of cancers of adult age that are rare in pediatric age, such as, for example, the colorectal cancer, basal cell carcinoma, or pheochromocytomas. Also, another point is in case children present with multiple primary tumors, either synchronous or metachronous. And here, another point for reflection is that the decision to address the child for genetic counseling is not only at the moment of the diagnosis, but should be reevaluated during the follow-up, because we can acquire further a new information. For example, of course, if the child presents with a second malignancy, but also if another member of the family present with a tumor in young age. So during the follow-up, this information should be regularly updated. Then, regarding the phenotypic features, we can have congenital anomalies, facial dysmorphism, intellectual disabilities, overgrowth syndromes such as generalized overgrowth syndromes or partial overgrowth syndromes such as the hemipertrophy. We can have macrocephaly and tall stature. On the other side, also growth failure is, for example, associated to the rasopathies. We can have hematologic abnormalities or immunodeficiency. And a point that it is often underestimated but quite important are the skin lesions. Here you see it's a long list of skin lesions that can be associated to cancer predisposition syndromes. And we are not talking about only the café au lait spots that everybody here is familiar with and evoke right away the diagnosis of neurofibromatosis, but also of constitutional mismatch repair disease. Here you can see we can have pilomatrixomas, nevi, lipomas, and a long list of skin lesions that we should keep in mind. Then, another criteria is the excessive toxicity following radio or chemotherapy. And then the seventh criteria, it's not a clinical criteria, but I decided to add it just as a suggestion. We have to consider also some tumor somatic characteristics, such as the chromotripsis or the hypermutated phenotype, because in some, or the BRCA signature, for example, because in some cases they can reveal the existence of an underlying germline mutation. Here, for example, you see that there are some tumors who can have a high tumor mutation burden, which could be associated to a mismatch repair gene disease. And now, very quickly, I will show you the results of a retrospective analysis on our cases here at Mitera, cases of cancer predisposition syndrome. We look back at the last 9 years, and we found out that we have diagnosed 20 children with germline pathogenic variants associated with cancer predisposition syndrome, and I'm not talking about the NF1 patients. Diagnoses that were done with the genetic testing. We also had 3 children with malignancies and clinical diagnosis of tuberous sclerosis. We had 12 and one that were treated as inpatient, which received some kind of treatment. We have one child with a nephroblastoma and a VUS in two cancer predisposition syndrome associated genes. We had one child with Hodgkin lymphoma and hereditary multiple osteochondrosis, but this association is not reported. And one child with medulloblastoma and chromosomically integrated herpes virus 6, for whom someone could just speculate if the integrated virus could have acted as an oncogene or not. But again, it's just a speculation. So we will focus only on the 23 patients that I evidenced with the red lines. The median age at the tumor diagnosis was 2.6 years, so a much lower age of diagnosis compared to the median age of our children. In half of the cases, we had the diagnosis of brain tumors. In 2 children, we had a neuroblastoma. In 2 children, a nephroblastoma. In the other, we had the miscellaneous of the other histologies. 13 children were tested with a whole exome sequencing. Interestingly, we had one ATRT who had a negative WES, but we found the deletion of the SMARCB1 with the Sanger sequencing. And then we had 5 children for whom the diagnosis was done with the Sanger sequencing for a specific gene, 3 cases of P53, 1 Noonan syndrome, and 1 Gorlin syndrome. If you look at the frequency of the pathogenic variants, we had 17% of P53 mutation, 14% of tuberous sclerosis complex, 9% of a mismatch repair gene variant, and 9% of APC pathogenic variants. In half of the children, we had an hereditary transmission, and we found other carriers in the family. In some cases, we knew it already. In some other cases, the diagnosis in the family was done following the diagnosis in the child. In 10 children, we had a de novo mutation, whereas in 2 cases, the family was not tested because in one case, the child was adopted, and in the other case, the family refused the test. We had also one child with 2 metachronous malignancies in the context of a Dicer-1 syndrome, and one child with a sonic hedgehog medulloblastoma who had 2 pathogenic variants. Okay. The number 6, who had a de novo mutation in the P53 and an inherited mutation of the RAD51 gene from the father's side, where there was an aunt that died of breast cancer at the young age. And also, in the bottom you see we have 2 very interesting cases of 2 siblings, one with a neuroblastoma and one with a nephroblastoma. I will not spoiler the gene because this will be presented by Dr. Dana. It's very interesting, so stay tuned. And then, for which reason we decided to test these children? In 6 children, it was because of family history, because of already known CPS in one of the 2 parents. In 2 children, the genetic testing was in the context of the INFORM study, which is finalized to the molecular characterization of the tumor in order to find target therapy. But there, in parallel, there is also the germline analysis. In 7 children, it was because of the type of tumor. 1 ATRT, 1 choroid plexus carcinoma, 2 sonic hedgehog medulloblastoma, 1 infantile myofibroma, 1 Gardner fibroma, and 1 lymphomatosis. In another case, It was because of prolonged toxicity following chemoradiotherapy. In another child, we had a bilateral nephroblastoma in a horseshoe kidney, so a synchronous tumor plus malformation. And in 3 children, it was because of dysmorphic feature. It is interesting to say also that in 3 patients, targeted therapies have been administered based on the results of the genetic testing. One case is the case of a child with a glioblastoma multiforme in the context of a constitutional mismatch repair disease who received checkpoint inhibitors at relapse, and with our big surprise, we observed a complete response of the tumor under nivolumab. In one patient, we had a neuroblastoma and the BRCA2 pathogenic variant. Here, we cannot say if the BRCA2 is the driver mutation, but at some point, at one of his many relapses, because were running out of therapeutic options, we decided to administer PARP inhibitors, and we had a partial response. In one other child, we had a medulloblastoma and an heterozygous PMS2 pathogenic variant. We gave the checkpoint inhibitors, but we had a progressive disease. And just to conclude, 5 children are currently followed with a full surveillance protocol for cancer predisposition syndrome. 3 have a Li-Fraumeni syndrome. 1 is the child with the constitutional mismatch repair, and 1 Gorlin syndrome. So, still, we cannot answer to the question, why do children get cancer? But maybe, at least in cases where we have a cancer predisposition syndrome, maybe we are one step closer to the answer. And maybe in the future, the knowledge of these diseases maybe will provide us with some further knowledge about the tumorigenesis of these complex diseases. Thank you very much.
This was a wonderful presentation, and I'm glad you also mentioned that in certain cases, like in the case we're going to be discussing today, genetic testing is absolutely indicated. Mm-hmm. Yeah. I was very interested in the case that you had a NF1, or it was, BRCA and RAD51D. You had a case. Two mutations. P53 and RAD51. So yes. I was interested. Was this the only case in the family that had both RAD51 and P53?
Yes, because the P53 was a de novo mutation, so none of the 2 parents had it. And but the father had the RAD51 mutation, and the father had a sister who died at a young age because of breast cancer.
And there was no prostate cancer in the family?
No, not yet.
I mean, again, this is also reminds us that we can see more than one tumor predisposing genes mutated on the same patient, which is fascinating. Thanks.
Είναι και αυτό το οποίο λέμε στους ογκολόγους, τους ενήλικες που έχουν ενήλικους ασθενείς, ότι θα πρέπει να κάνουν ένα full έλεγχο γονιδιακό συνήθως, γιατί υπάρχουν και αυτά, όλο αποκαλύπτονται και περισσότερα σύνδρομα, ή μάλλον προδιάθεση καρκίνου που έχουν δύο διαφορετικά γονίδια με μετάλλαξη. Τα δεδομένα δείχνουν, και αυτή ήταν μια εξαιρετική ομιλία, ότι στα παιδιά τα οποία έχουν επιβιώσει του παιδιατρικού καρκίνου προτείνεται να γίνει γονιδιακός έλεγχος, ακόμα και στην ενήλικη του ζωή, και για reproductive options, δηλαδή για να ξέρουν τι θα κάνουν μετέπειτα στη ζωή τους, και για να ξέρουν αν έχουν κίνδυνο να κάνουν κάποια άλλη μορφή καρκίνου και να είναι under surveillance για αυτές τις μορφές καρκίνου. Καταλαβαίνω το δικαίωμα του ανήλικου παιδιού, είναι κάτι το οποίο έχω δουλέψει, μα δεν ερχόμαστε να μιλήσουμε για ένα ανήλικο παιδί που είναι υγιές, ερχόμαστε να μιλήσουμε για ένα ανήλικο παιδί που πάσχει, και το να βρούμε τι φταίει, θα μπορούσαμε να συζητήσουμε περισσότερο αν θα καταγράφουμε τα αβέβαιης κλινικής σημασίας ευρήματα, σε ένα παιδί που είναι ανήλικο και δεν ξέρουμε τι να κάνουμε με τα αποτελέσματα. Εξάλλου και στους ενήλικες το ίδιο κάνουμε, το συζητάμε, το φιλτράρουμε πριν δώσουμε ένα τέτοιο αποτέλεσμα. Τα VUS είναι αβέβαιης ή άγνωστης κλινικής σημασίας. Πολλά από αυτά μελλοντικά γράφουμε πλέον κάτω από τις απαντήσεις μας ότι στην πορεία των χρόνων τα αβέβαιης επανεξετάζονται ή γίνονται benign, δηλαδή καμία κλινική σημασία, ή μπαίνουν στην κατηγορία του παθολογικού και πρέπει να ενημερώσουμε την οικογένεια. Έχουν αλλάξει τα πράγματα πολύ. Ερωτήσεις, κύριε Πουτσίδη?
Εκτός από τον οικογενειακό προγραμματισμό, για ποιο λόγο ένας υγιής, ασυμπτωματικός ενήλικας να κάνει γενετικό τεστ?
Δεν συζητήσαμε να κάνει γενετικό τεστ ένας ενήλικας.
Να κάνει τον έλεγχο.
Λοιπόν,
το screening.
Δεν υπάρχει λόγος, αν δεν υπάρχει οικογενειακό ιστορικό, όμως, και αυτό θα σας το πει και ο κύριος Τάκης, υπάρχουν καινούρια δεδομένα και προτάσεις που μπορεί να γίνει έλεγχος σε μία σειρά γονιδίων προληπτικά, αλλά αυτό είναι επιλογή ενήλικων ατόμων που θέλουν να το κάνουν, για να δουν αν έχουν κάποια γνωστή μετάλλαξη σε γονίδια που σχετίζονται με προδιάθεση ανάπτυξη κάποιων μορφών καρκίνου, καρδιάς ή κάποιων άλλων νοσημάτων, για τα οποία υπάρχει ιατρική παρέμβαση και πρόληψη. Είτε αυτό λέγεται μπρουγκάντα, καρδιά, long QT, κάποιες μορφές καρκίνου που υπάρχει πρόληψη. Είναι γεγονός, είναι 74 τα actionable γονίδια αυτή τη στιγμή και τα κάνει όποιος επιθυμεί μετά από συμβουλευτική, αλλά όχι όποιος.
Και από τους 100 που θα τα ξέρουν αυτά τα γονίδια, πόσοι θα πάθουν καρκίνο?
Αυτό είναι μία άλλη ιστορία, την οποία πριν κάνουν τον έλεγχο, την συζητάμε με τους ανθρώπους που θέλουν να το κάνουν, έτσι. Η κυρία Πολυχρονοπούλου, διευθύντρια στο ΤΑΟ.
Ευχαριστώ πάρα πολύ. Dear Vita, I will speak in English. I think you can manage it better a little bit. That was a really interesting presentation. Your data was very interesting, and I think that, of course, this should be communicated to larger meetings, to this meeting and to other larger meetings, and perhaps you can publish them in a way. You will find out which will be the most interesting point of all of this, but for us and for me personally, it was really very interesting. Because the subject is the screening in our cancer patients and not in healthy ones, in healthy adults, I would like to ask you, what is the surveillance program under which those patients that are surveyed is now? What does it include? And how many different specialties does it include? Or do you have an algorithm for that? And my second question is, because we also follow the Youngman criteria for our patients, and I think you have the opportunity to discuss all these issues in the new group that is formed within the Hellenic Society of Pediatric Hematology Oncology, that is the genetic predisposition syndromes under the guidance of Dr. Katamis. And you will establish for all departments perhaps some structured criteria, if we follow the Youngman or if we follow the other type of criteria. So also the whole Hellenic Society can have some uniform approach. But the laboratory approach is what makes me to feel more concerned. Because as you showed, there were some that were missed by the WES and were found targetedly looked for by Sanger. So I think you should also propose a structured way how to approach this. For example, if we have a disease, let's go first with Sanger. If we don't have, let's go for a WES. And if this fails, what can be the next step? I think these two, the surveillance and how do you approach on a laboratory basis. Thank you.
For the surveillance, the CEOP host genome working group is working very actively on the reduction of guidelines for these conditions. So in this moment, there are guidelines for the the Lifraumeni, we have the Toronto Protocol. So we follow this protocol, and our children are followed with the whole body magnetic resonance once a year. Then there is the follow-up of the brain tumors. If it is not a child with the brain tumors, brain MRI is suggested every 6 months, alternated with the total body MRI. Abdominal ultrasound every 4 months. Dermatological exams once per year. What else? And then at the older age, in the adults, breast MRI for women every once per year. Here again, alternated with the total body MRI and gastrocolonoscopy. Then, regarding the blood test, there is a little bit of not everybody is agree if it is how useful it is and how often, because if we want to screen and diagnose, do early diagnosis of a leukemia, we cannot do tests every 15 days. But of course we can diagnose myelodysplastic syndrome, for example. So our attitude is we do blood tests to the child who received chemotherapy, not necessarily to the other carriers in the family. For constitutional mismatch repair disease, there are also established guidelines. Now, one subject for discussion is if the place for total body MRI in these patients. It seems that maybe, but again, it's ongoing discussion. The French group showed that maybe we can avoid the total body MRI, but there again, for example, this is my point, I don't understand why in Lifraumeni we do it and why in the constitutional we don't do it, but I just reported what's going on. This child, it's an interesting case because he also had multiple colon adenomas, so he received gastrocolonoscopy once per year. The Erne Gentouris group on CMMRD is writing through a Delphi process guidelines for the follow-up of these children, not only for the follow-up, for the diagnosis, for the treatment, for the follow-up, for the genetic fertility counseling. And so I had the chance to review this, to participate to the Delphi process. So I know that very soon these guidelines will be available with all the exams that we have to suggest with these patients. For the Gorlin, there are also guidelines by the CEOP group. So many of these diseases, that's why it is important to identify the disease, because they are actionable, which means through the surveillance protocol we can really improve the survival of this patient, but also of the other potential carrier in the family. So this is for the first question. Please, help.
For one thing, was it Sanger sequencing that detected the deletion, or perhaps MLPA, which is completely different technology?
Could have been the MLPA.
MLPA,
yes.
So it's completely different. Wes, just as every methodology, να τα πω ελληνικά ή θέλετε αγγλικά?
Ελληνικά.
Καταλαβαίνετε,
Καταλαβαίνω.
επειδή το ξέρω. Κάθε μεθοδολογία έχει τα υπέρ και τα κατά. Το WES είναι μια πάρα πολύ καλή μέθοδος, αλλά και αυτή μπορεί να χάσει κάποια πράγματα. Το Sanger δεν κάνει για ελλείψεις και διπλασιασμούς μεγάλους. Τα copy number variations, όπως λέγονται, που είναι μεγάλα κομμάτια ελλείψεων και διπλασιασμών, τα πιάνει το whole exome sequencing, αλλά κάποια μπορεί να τα χάσει. Γι' αυτό και η συνεργασία με τον ογκολόγο είναι εξαιρετικά σημαντική, γιατί ξέροντας ότι επιμένει ότι ή εμείς βλέποντας τα εργαστηριακά και την κλινική εικόνα του ασθενούς, που είναι τόσο σημαντική να μας τα λέτε, ψάχνουμε τη βιβλιογραφία και βλέπουμε ένα ποσοστό τόσο τα 100 θα είναι μεταλλάξεις και ένα ποσοστό επί αρνητικού αποτελέσματος θα είναι μία έλλειψη ή ένας διπλασιασμός. Δεν τον έχω πιάσει, αλλά η κλινική εικόνα, ο φαινότυπος του ασθενούς μου χτυπάει καμπανάκια. Θα βρω τις άλλες μεθόδους να τις βάλω. Είναι πολύ σημαντικό να έχουμε μια εξαιρετικά λεπτομερή κλινική εικόνα από εσάς για να διαλέγουμε τις κατάλληλες μεθοδολογίες. Δεν υπάρχει πανάκια για τίποτα, ιδίως για το ΣΜΑΚ, που είναι ένα μοριακό defect που θα προκαλέσει το νόσημα. MLPA πρέπει να ήταν, γιατί νομίζω ξέρω το περιστατικό. Θέλω να πω ότι δεν θα κάνουμε Sanger, είναι πολύ παλαιομοδίτικο. Το Sanger, όταν υπάρχουν σημειακές μεταλλάξεις ή μικρές ελλείψεις ή διπλασιασμοί, θα το κάνουμε για επιβεβαίωση, ούτως ή άλλως. Για άλλα πράγματα θα χρησιμοποιήσουμε άλλες μεθοδολογίες και η συνεργασία είναι εξαιρετικά σημαντική μεταξύ του εργαστηρίου και των ογκολόγων για να μπορούμε να φτάνουμε στο βέλτιστο αποτέλεσμα. Δεν υπάρχει το πατάω ένα κουμπί και βγαίνει ένα αποτέλεσμα. Αυτό είναι στις λιγότερες περιπτώσεις, στις περισσότερες θέλει copious work.
Ένα negative West
ναι.
δεν σημαίνει
όχι. Ένα negative West, να σας δώσω ένα παράδειγμα, σε ένα φανκόνι που οι γονείς δεν έχουν καμία συγγένεια, είναι απίθανο να έχει 2 μικρές ελλείψεις που θα τις έπιανα με τα copy number variations. Αλλά, αν έχω μία φανκόνι μετάλλαξη και δεν βλέπω δεύτερη, οφείλω να ψάξω, αφού είναι μου την έχει στείλει ο γιατρός για φανκόνι, οφείλω να ψάξω ποια άλλη μεθοδολογία θα μου αποκαλύψει τη δεύτερη μετάλλαξη. Είναι λοιπόν κάτι, πείτε, παρακαλώ.
Όχι, απλά συμφωνώ απόλυτα. Ήθελα και εγώ να πω ότι δεν μπορούμε να χρησιμοποιήσουμε το ερώτημα Wes ή Sanger, ακριβώς γιατί για κάθε διάγνωση θα πρέπει να χρησιμοποιηθεί η καταλληλότερη τεχνολογία. Αυτό που θέλω να πω επίσης είναι να μην ξεχνάμε και το μοσαϊκισμό, το οποίο είναι εξαιρετικά σημαντικό, όπως καταλαβαίνουμε, στα παιδιά ειδικά, και εδώ γίνεται ακόμα πιο δύσκολη η επιλογή της μεθόδου. Επομένως, ο μοσαϊκισμός φαίνεται να εξηγεί ένα ποσοστό, να σας δώσω ένα συνολικό νούμερο, βεβαίως κάθε νόσος είναι διαφορετική, αλλά ο μοσαϊκισμός, ειδικά σε περιπτώσεις συνδρόμων που υποδιαθέτουν στον καρκίνο, μπορεί να είναι τόσο συχνός όσο 2 με 5%, που είναι μεγάλο νούμερο. Οπότε αυτό επίσης αλλάζει πάρα πολύ τη μέθοδο που θα χρησιμοποιήσει κανείς. Αυτό ήθελα να προσθέσω. Ευχαριστώ. Το νούμερο αυτό που χρησιμοποίησα είναι από τις μεθόδους στους ενήλικες. Δεν ξέρουμε για τα παιδιά ακόμα. Δεν ξέρουμε για τα παιδιά.
Μικρό αυτό. PIK3CA, για να πω λίγο, γιατί είπατε για μοσαϊκό. Το PIK3CA, για το οποίο υπάρχει και θεραπευτική προσέγγιση στα overgrowth σύνδρομα, είναι μοσαϊκά. Λοιπόν, παιδί που μας χτυπάει καμπανάκι με κάποια εξωτερικά χαρακτηριστικά συν τον καρκίνο του, πρέπει να σκεφτόμαστε και αυτή την προσέγγιση ότι μπορεί να έχω ένα μοσαϊκό. Κάθε περίπτωση είναι διαφορετική επί της ουσίας. Πρέπει να προχωρήσουμε.
Μήπως γι' αυτό έχει σημασία και η μοριακή ανάλυση του όγκου.
Δεν το συζητώ αυτό. Αυτό είναι εκ του ουκάν.
Που μπορεί να μας οδηγήσεις μερικές φορές.
Να επιτρέψω στον κύριο Κατάπη να κάνει μια ερώτηση ακόμα.
Για την πολύ ωραία παρουσίαση που έδειξε και τις ανάγκες και την ανάγκη για πολυδιάστατη προσέγγιση, και αυτό είναι πολύ σημαντικό, κάτι που έχουμε φτιάξει στο Gentouris, όπως ξέρετε, σαν κέντρο εμπειρογνωμοσύνης και στο κέντρο μας. Νομίζω ότι τα guidelines, υπάρχουν guidelines, οπότε άμα θέλει να τα βρεις υπάρχουν. Εμείς σαν ομάδα θα πρέπει να αποφασίσουμε ποια από τα 5 guidelines θα υιοθετήσουμε, τότε να υπάρχει μια νέα γραμμή, αλλά παρόλα αυτά τα guidelines υπάρχουν. Ένα μεγάλο ερώτημα και ένα μεγάλο πρόβλημα που έχουμε και εμείς, τι κάνετε εσείς με τους ενήλικες ασθενείς? Γιατί βρίσκεις το παιδί, βρίσκεις το γονέα, πού τον παραπέμπτεις? Τι κάνετε εσείς? Yeah, but yeah, that's the main problem. We don't have any centers. But there's no centers for CPS for adults. That's the problem.
Σας ευχαριστούμε πάρα πολύ για την παρουσίαση. Νομίζω πρέπει να προχωρήσουμε στο επόμενο.